Running on time, everyone. We're going to wait a few more seconds. So we're well over 100 nearly, and then we'll get started. Just so everyone's aware, there are two options in the chat. One is to write to the panelists, one is to write to all attendees. I'd encourage you to write to all attendees. I'm sure they'll share your experiences and your feelings as well. Right, I think we'll get started. Tesh, I think the recording started as well. Yep. Let's kick off then. So hi everyone. My name is Elliot Paris. A warm welcome and a happy Friday to everyone. Axel and Hanzo and myself are co-founders of Embrace. I'll be the host of today in the presence of our three guest speakers who I'm excited to introduce you to all shortly. Just a bit of housekeeping before we start. Your engagement, your comments, your questions, concerns, and suggestions are all essential. Please use the chat function to engage with each other and the panelists. You'll see two options, as I mentioned before. If you check your message going to all panelists and attendees, just to make sure that you are speaking to everyone. Please also use the Q&A function if you want a specific question answered at the end of the hour. I say the end of the hour, in an hour roughly, we'll go on to answering those specific questions if we can't do them during the discussion. I'll monitor both as we go. So in June, following the murder of George Floyd, Elsevier's CEO, Kumsal Bayazit, made this statement on the screen right now. Confronted with the stark reality of systemic inequality in society, we need to re-examine Elsevier's role in research and health. We all need to re-examine our roles in our spheres of influence and how we can actively make positive contributions to accelerate equity, inclusion, and diversity, both within our organizations and in the communities we serve. Elsevier stands in solidarity with Black communities because Black lives matter. It is not enough to identify as not being racist. Each panel discussion in this three-part series is designed to enable you to have more impact as an anti-racist. Ongoing initiatives will be shared, use them and adapt them as you please. For our second discussion, we'll focus mainly on the second goal of the three-part series to empower scholar activism and eliminate systemic racism in academia, research, and healthcare. The other goals of the three-part series are to promote a culture of psychological safety, inclusion, diversity, and catalyze anti-racist initiatives, which is what we focused on last week. And the third goal, which is next week, we'll focus on support grassroots activism with our skills, influence, and resources for institutional changes. We will also go over both of those things today as well. I'll openly discuss my personal experiences and opinions, as will our panelists, who it's about time I introduce to you all. So Dr. Ndidi Amaka Amuta Onukugaga is an Associate Professor of Public Health and Community Medicine at Tufts University School of Medicine, where she chairs the Diversity, Equity and Anti-Racism Council. Ndidi is a scholar activist and has a long-standing commitment to public health that spans over 15 years of public health experience. Her current expertise and research interests include health disparities, reproductive health, maternity, and infant mortality and HIV/AIDS in ethnic minority populations. Dr. Amuta Onugaga is a certified health education specialist. She has taught courses on program planning and evaluation and minority women's health. She's a force working within and outside her organizations. I can attest to that from our conversations in the past few days and months. And she's a positive influence to eliminate racism in all of its forms. I'll briefly introduce you, Ndidi, and say thank you for joining us. It is a pleasure to have you on today.
Thank you, Elliot. I'm excited to be here.
I'd be lying if I said I had the pleasure of knowing our next panelist as well as Ndidi knows her, but I'm excited to also introduce Dr. Sherelle Barber. She's an assistant professor at Drexel University's Dornsife School of Public Health. Sherelle is a social epidemiologist whose research focuses on the intersection of place, race, and health. Her work is framed through a structural racism lens grounded in interdisciplinary theories such as eco-social theory and critical race theory, which we'll come on to later on. For empirical evidence, her work seeks to document how racism becomes embodied through the neighborhood context, also how this fundamental structural determinant of racial health inequities can be leveraged for transformative change, both through anti-racist policy initiatives. Dr. Barber is committed to using her scholarship to make the invisible visible, mobilize data for action, and contribute to the transnational dialogue around racism and health inequities. Again, thanks for making the time to join us today, Sherelle.
Thank you so much for the invitation, Elliot.
And our last panelist, I wasn't lucky enough to work with in my time at University College London, but his feedback on a nonprofit called Track Together I volunteered for to support the NHS through COVID-19 led us to speaking further. And a lot of emails chasing you down as well, Delan. Dr. Delan Javan Devakumar is an associate professor in child and adolescent health at University College London. Delan is an honorary consultant in Public Health England. Delan is chair of the International Child Health Group, which is a specialty group of the Royal College of Paediatricians and Child Health. He was a steering group member of the UCL and Lancet Commission on Migration and Health, and is currently lead for child and adolescent health in the Lancet Migration. He is the lead for the upcoming Lancet series on racism and xenophobia and chair of race and health. Delan also works on humanitarian crisis and conflict, mental health, nutrition, and violence, and is committed to public engagement and advocacy to improve health. Thank you for agreeing to share further with us as well, Delan.
Great, thanks for inviting me.
Okay. I think we'll jump straight into the first question, and let me end my screen share. There we go. So the first question I thought we could look at is building on what we were talking about last week, which was around Elsevier's internal activism and anti-racist initiatives that our audience could adapt and use. Perhaps Ndidi and Sherelle, could you share some of your challenges that you've overcome as scholar activists and introduce ongoing anti-racism initiatives within your own academic institutions?
Right. Good morning, everyone. I'm really excited to be here for this important discussion. Some of the challenges, I think, and I've said this even in my own institution, I sit in the School of Medicine, are that oftentimes, and you may also be experiencing this, Elliot, in your institution, oftentimes when you are trying to combat these systems of structural racism, you find that you're one of few Black people in these institutions. And I think that really kind of sets you up for one, an uphill battle, and two, the support that you need. So I've definitely seen when I started my career as an assistant professor, I was one of 40 new hires. In my previous institution, I was the only Black. And now in the School of Medicine, I'm one of 2 Black women. And so there is definitely something to be said for the paucity of researchers. And as you go up the chain, we know that there are less African-American women that make it to full professor or associate professor or deans or provosts or these positions of power. And so, not that the solving of the situation should be squarely on the shoulders of Black people. But I think having that paucity of representation, one, for the training of future clinicians and public health professionals, right? Being able to connect with the students and really bring your lived experience and your narrative to the classroom. And two, trying to dismantle the systems within the system when you're one of very few has been a challenge that I've definitely faced.
Thank you. I'll take a stab at that. And I actually want to step back a little bit to, first, answer the question of why scholar activism is so important, right? And so for me, coming into the field of public health, which by definition is about preventing death and preventing suffering, knowledge should lead to action. And the understanding that racial inequities, particularly among Blacks and other marginalized racial groups in the United States, have been structured by systems and power structures that have contributed to the racial inequities. And so an engagement with these power structures is actually necessary to, reach the goals of eliminating health inequities, right? So, I start there in terms of why even a scholar activism orientation is necessary. Then, thinking about the ways in which activism and protests have just kind of emerged, especially in the last 10 years. I graduated, with my doctoral degree from Harvard in 2014 at, when the Black Lives Matter movement was, really evolving with the murders of Mike Brown and Eric Garner in New York City. Had to kind of bear witness collectively, with the kind of murders of others like Breonna Taylor, George Floyd, et cetera, recognizing that these are all parts of systems and structures that need to be dismantled. And so, it's almost no longer an option to remain kind of just an academic. You have to be engaged with these issues if we're really going to dismantle the structures. And particularly with this COVID-19 pandemic, this has just, again, been, just a necessary orientation where I'm no longer, content with observing inequities, but also wanting to disrupt those inequities. So scholar activism grows out of that. It grows out of the moment, the need, the necessity to engage. And it is challenging because the value system within the academy often sidelines that orientation. It puts credence in production for the sake of production oftentimes, and doesn't value the kinds of actions that are trying to be engaged both within the academy, but also publicly. Where I found strength is in the collective connections with folks like Ndidi, with scholars across the country, where we build networks of scholars outside of our institutions to really, one, learn from one another, provide support for one another, and think about how we can use our collective strength, our collective knowledge to really challenge not only the systems and structures that create racial inequities, but the systems and structures that also produce knowledge, right? Because we really, are a counter narrative within a field that has said that racism is, in some ways marginal to the explanations that would, give rise to these racial inequities. And so this collective scholarship, collective activism has been a really powerful tool of being able to engage in this way and engage in this moment as scholar activists.
You mentioned there the systems and structures that produce knowledge, and I suppose academic institutions are at the forefront of that. So I'm thinking, do you have examples at the moment of maybe unconscious bias that you're trying to address in all of your institutions?
Right. I think sometimes it has to do, for example, with our models of promotion and tenure. Again, what gets valued in terms of who gets promoted? Is it, that someone has produced, for example, 20 or 30 publications, or is it someone who has engaged with communities in a deep process of community building and trust building, et cetera? Maybe not having the number of publications, right, that people say is necessary, for promotion, but having having done the kind of deep work that's necessary to really move these structures, right? So there's an imbalance, right, sometimes within the walls of the academy in terms of whose voices are heard, what is seen as productive, right? And so I think those are some of the barriers within institutions that we need to contend with if we are going to actually diversify and include and create equitable terrain for those of us who are really trying to, address these very complex issues.
It's complex, and I feel like inclusion has to come before diversity as well. It can't be a mandated thing, otherwise ultimately it's not going to happen and nothing's going to change. I think I might touch on some of the things you mentioned earlier on, Ndidi, in your first statement. So you were mentioning, I suppose, the work that you're doing within your institution, specifically in relation to the people that you're teaching. Maybe you could elaborate a bit more on, I suppose, maybe what you're trying to teach them through this anti-racist initiative at the moment, or movement, I should say.
Sure, thank you. So some colleagues and I have developed, so I sit in the School of Medicine, as I said, and some colleagues and I have developed an anti-racism curriculum that we're implementing with our second and fourth year medical students. And it's a 3-part curriculum, 2.5 hours. We have implemented it with 26 students so far who are going to be OBGYNs, family medicine doctors, et cetera. And it's been a really eye-opening experience for the students. One, the students of color, it's like, hello, this is my lived experience. There's nothing in it that they haven't already felt being Black in America. But for some of our white students, the majority of our white students, and even some of our students that identify as South Asian, Middle Eastern, et cetera, I think it has been a really eye-opening experience to sit in their privilege and to really understand the impact of racism, how they have been unduly privileged and how the systems have been set up to benefit them, meritoriously or not, and how do they work within the healthcare system to dismantle that? What do they do when one of their fellow students or fellow residents is chastised, disciplined, ignored, disrespected by a patient or an attending? What do you do when you're confronted with racism in a clinical encounter? And just how to actively provide the best health care possible. What does it mean to be culturally humble? And so the curriculum was a little bit of an uphill battle to get the administration to really support it, because we're talking about white fragility, we're talking about anti-racism, we're talking about structural oppression, we're talking about all the things that really white people are difficult or hard to grapple with, and it makes people uncomfortable. But if we know the impact of not having these conversations, we know the impact of racism on healthcare, right? Look at the disproportionate burden of COVID-19 deaths. Look at what we're seeing in maternal mortality. Look what we're seeing with Black people interacting with police and being killed by police. Like, the not talking about racism doesn't make it go away. I wish it did, but it doesn't. And so how do we train clinicians and future healthcare providers, and ultimately the top percentage of people in the country? These people are making $400,000, $500,000, $600,000 in about 5 years. How do you get them to really understand their role in dismantling racism? So we just had a paper come out in the Journal of Academic Medicine called Struggles and Tensions, really reflecting on the lessons that we learned in developing and implementing this anti-racism curriculum. We just received some small pilot funding to expand the curriculum to other medical schools. So we're in talks with a couple medical schools around the country who have approached us and say, hey, we're also struggling with training our students. How do we get clinicians and healthcare providers to really understand the role that they play in dismantling racism? So I'm happy to talk further, but that's kind of what we've done so far.
I wonder if any of the panelists have any other comments. Otherwise, I'm going to carry on asking questions here. I'm going to go for it. So, so I think picking up on first of all, the comment on particularly mortality in Black females, I've noticed data on that recently out of the UK. So I want to make this clear that this is not something which is isolated to the US. This is a global issue. So there's data from a group called Embrace, not the same as Embrace. I'd consider some copyright infringement there, but the data that they've given is that Black women are 5 times more likely to die during pregnancy and after childbirth compared to their white counterparts. When you look at people of Asian backgrounds, it's double. When you look at women of mixed ethnicity, the risk is 3-fold. I just want to put that data there just so people are aware, and I'm sure Ndidi and Sherelle and Delan, you could add a lot more insight onto that as well.
I can start.
Okay, great.
Yeah, I can start. So I am very disturbed to see that the trends that we're seeing in the United States are also magnified in Black women in the UK, but it reaffirms the basis of the disparity, which we know is racism. Okay, so it's not about access to healthcare. It's not about not having the best technology. It's not about women not knowing that they need care. Like this narrative around low income women and having poor birth outcomes and poor maternal outcomes, we have to really shift that narrative because we know that even for women that are like Sherelle and I, professional, high education, high salary, we still see these disproportionate burden of maternal mortality and maternal morbidity. So you ask yourself, what is the underlying factor that kind of connects what we're seeing with the Black women in the United States and also is what we're seeing in UK, and that's racism by the system. For those of us in the United States, you guys, I'm sure have heard it as well. Serena Williams had a near-death experience, and in maternal morbidity world, we call that a near miss, meaning it could have gone the wrong way, and we would have lost a global superstar because of racism. So after she delivered her baby, she was complaining that she was having some pain and some complications. The nurses were like, "Oh, you just had a baby, go and rest," which is so dismissive. Nobody was even trying to take her seriously. And she persisted and persisted. She said, "No, I actually have blood clots, and I was dealing with this before, but I got off the medication because of the pregnancy." And so she persisted and got a CT scan, and they found a huge blood clot that was forming in her lung, which could have killed her. Now, what type of global stain of embarrassment and disgrace would that have been on the United States for us to lose a beloved world-class athlete because of the dismissiveness? Beyonce also talks about it. So I bring up these two more famous examples because everyone in the world knows who they are, but I use them to really further illustrate that these women have access to the best healthcare. They're delivering in the world-class institutions. They have private teams that can fly them anywhere, and they still both almost died due to racism. Beyonce had preeclampsia when she was pregnant with her twins, which is a very dangerous condition. So I use those as examples to amplify just the depth of the impact of racism and to really underscore the importance for dismantling the system, really holding healthcare professionals accountable. It's not just enough to do an implicit bias training or workshop once a year and they get their continuing medical education credits. That's not going to cut it. What we need to do is to buffer the teams with additional resources, doulas, midwives, birthing centers, so women have options. Women and birthing people have options outside of traditional healthcare systems that continue to fail them. So I'm happy to talk more about some of the research I'm doing, but that's just my initial gut reaction to what you're saying is that, of course, we're seeing the same thing in UK because Black women are also marginalized and Black women are also disrespected. And racism is also pervasive over there. I'm not surprised. I'm disheartened, but I'm not surprised at the rate. So I don't know if you want to add anything, Dr. Barber.
I think Delan, maybe you could add some context from the UK standpoint as well.
Sure, I'll come in. Thank you. And I agree, and it's very powerful what Ndidi was saying about this. It's very much a similar picture in the US and the UK in terms of maternal mortality, but it's not just mortality; it's also morbidity. If we look at breast cancer rates, endometriosis, mental health, these are all the rates are much higher amongst Black women in particular, and also for the children, the infants who are born, higher rates of preterm birth, low birth weight, stillbirths about double amongst Black women in the UK. So this isn't just one issue; these are multiple health outcomes that are related to the same thing. And I do think the US is a little bit further ahead in terms of calling out this as racism. In the UK, the Embrace report, I think, didn't do that explicitly, though other reports have subsequently. And it relates partly to institutional structural racism that leads to poor housing, low income, the increase in risk factors that Black and minority ethnic women face, and also just to racism itself. So overt acts of racism and unconscious acts of racism as well. So there are different pathways by which this may act. And I think we bring in the kind of the intersectionality issue here in particular. So indeed, you mentioned Serena Williams, who's a very good example of someone very famous, very powerful in that respect, and it still happened to her. But these are issues that affect poorer people much more, people in the lower socioeconomic levels much more than richer people. And when that's combined with acts of racism, this has a multiplicative effect. I mean, what can we do? So the RCOG, the Royal College of Obstetricians and Gynecologists, came out with a report subsequently on this. And they did call out racial biases. They talked about the negative influences that Black women in particular face in terms of the kind of treatments they get, the opportunities for treatments, pain management. Simple things like pain management are different, and Black women receive less pain control than other groups. And also, this has the effect of the groups themselves. So Black women, minority women are less likely to get treatment, less likely to go to the doctors for treatment, which has a sort of a circular effect, and it multiplies. I found out one example. So I was reading a little bit about this, and there's an article by an obstetrician called Amali Loku Kagame, who describes a situation in New Zealand where they had this checklist, this cultural safety checklist, which I thought was very interesting. And what they do is that, similar to the kind of surgical checklists that are pretty common, this checklist is for health professionals to think of their own biases, to think of their own privileges, potential power imbalances, and in the New Zealand settings, particularly for Pacific Island people, for the Maori populations, and to think about how you may interact before you go into the consultation with the patient. And I think more work needs to be done on these things, and to evaluate how effective they are. But these are some of the initial things to make that unconscious bias very conscious, so that you think about these actions before you go into the consultation. And finally, the Embrace report calls for more research. The RCOG report calls for more research, and as researchers, we always call for more research, and that's certainly important. We need to see how effective these interventions are. But part of this is just a rights issue. This isn't about how effective some things are. This is about people getting quality healthcare, access to healthcare, getting treated properly. So a lot of these are rights issues that, regardless of effectiveness, they should be in place. Thank you.
Thanks, Dylan. I wholeheartedly agree as well. I think we could perhaps touch on, before we move on to a slightly different topic, we can maybe touch on that in terms of how can we start ensuring that these recommendations that happen are actually implemented into policy to actually impact human rights, or maybe just some examples of that. I wonder if anyone wanted to comment on that.
So here in Massachusetts, I sit on the COVID-19 Maternal Equity Coalition, and I've also been instrumental in getting some legislation passed in the House of Representatives here, particular Bill H 4818, which calls for a maternal mortality commission. And it's different than the state level maternal mortality review commission, which is housed under the State Department of Health. This is an independent body comprised of public health researchers, clinicians, doulas, midwives, women that have experienced a near-death experience themselves, and it would be appointed by the governor, and we would meet for a year and provide recommendations. So in all things politics, it's actually held up right now in the Senate, because so it passed the House of Representatives. We had a really good champion. I really want to give a shout out to Liz Miranda, one of our state senators, who's really pushed the work forward in a really deliberate, intentional way, as one of like 3 Black women in Massachusetts State House of Representatives. And so she's a champion of this. But when it got to the Senate, it got stalled because thank you. Wow, you guys are on it. The Senate had some problems with the language, because, and I am one of many people that wrote the language explicitly saying that we should have an overwhelming majority of the commission led and staffed by Black women. Black women are the ones disproportionately burdened by this. So that made people uncomfortable, because they're trying to take a crisis, a maternal health crisis that's impacting Black women, and turn it into a political circus. And so it's kind of stalled right now. And so now we're going back and forth with the language. Is it going to be Black women? Is it going to be ethnic minority women? So that's kind of where it is. But that legislation at least got through the House, and I've also contributed to some legislation on the federal level, working with Representative Underwood. Shout out to her from Illinois, and our state senator Elizabeth Warren, who have done some things looking at maternal mortality and mental health. So I think we have a ways to go, but there are things moving. I definitely want to lift up the work of the Momnibus bill, which is a suite of 9 bills that was introduced by Representative Lauren Underwood and represent from Illinois, and Representative Alma Adams from North Carolina. And we have the Black Maternal Health Caucus that really has taken this up at the congressional level. And so I think that's amazing, and we have further to go. And this is also getting on the radar of other organizations federally. So on November 13th, I will be testifying in front of the United States Commission on Civil Rights on maternal health disparities as a civil rights issue. And so I think we're getting there, we're getting some traction, but I think we have a ways to go. So if anybody's interested, I can chat more, but those are some of the recent policy and legislative things that have come out of this work.
Thanks, Ndidi. And I've seen some questions pop up in the chat, which we could address at the end, because I feel that they actually relate to some of the questions that the audience shared with us in advance. Mentioned to Nadesh in particular. What we'll do now is we'll quickly move on to a hot topic, unfortunately, across the world, which that is COVID-19. I think you can all comment in great depth on this subject. And what I'd like to discuss is why people from Black and Brown communities are disproportionately impacted by COVID-19. We could maybe start off by maybe focusing on Delan, maybe if you could kick us off, just to start us off, and we can go into just the context of minority groups and migrants.
Sure. Thank you. So particularly from a UK context, there have been a number of analyses, quantitative analyses, looking at mortality amongst minority populations in the UK, and I mean, including our own group led by my colleague, Professor Rob Aldrich, noticed this increase in mortality amongst minority groups. This has been replicated with the ONS data, the Office for National Statistics, Public Health England, and a number of other analyses. The ONS data, I think, found a 4.7% increase in mortality amongst Black men compared to the white population, 4.3 times increase for Pakistani, Bangladeshi men. They then control for certain factors if you take into account where someone lives, for example, and some other socioeconomic factors. This came down to around a 3 times increase for Black men, around a 2.5 times increase for Pakistani, Bangladeshi men. And all the analyses have similar kinds of numbers. Some of the numbers are a little bit different, but we see this increase in mortality amongst men and women of minority groups, with the Black population having the highest mortality in general. So why does this happen? I think there are broadly 2 reasons. Minority groups are more likely to get infected in the first place, and then to have increased morbidity and mortality from that infection, the COVID-19 infection. So the increased risk of more getting the infection. So we see that the kinds of housing that people live in, people in lower socioeconomic groups live in overcrowded housing and smaller kinds of housing where it's an increased risk of passing from one person to the other. And then the kinds of work that people do. So if you work in insecure form of employment, it's not easy to stop working. You have to continue working. And even the kinds of occupations, so Black populations in the UK are more likely to work in social care, for example. Pakistani, Bangladeshi populations more likely to work in sales and sort of person-facing industries, where that puts you at increased risk of getting COVID-19. And then the second reason is some slightly more institutional causes. So we have an NHS that's free at the point of access for everyone, but it's not entirely free at the point of access. So if we look at migrant groups, there's a charging regime for migrants in the UK, which acts as a barrier to accessing the health service. And the interesting thing is that actually COVID-19 treatment is free, But if you go with symptoms, you don't know what you have. And if you turn out to have something else, you will be charged for that. And it also acts as a barrier in that people don't understand the health service. I mean, doctors don't understand the health service well enough to know who is charged, who isn't charged, what they're charged for, what the exemptions are. So it's kind of normal to be concerned about this. And this is on the back of the hostile environment in the UK towards migrants. And the NHS is sadly part of that hostile environment. NHS data was shared with the Home Office, for example. Charging data was shared with the Home Office. So people are obviously fearful of going to hospitals for treatment. And this barrier isn't good for anyone. This isn't good for the migrant groups themselves, but it isn't good for everyone else to have people who are at risk of COVID-19. And the other final part is the increase in non-communicable diseases. So certain groups are more likely to have a non-communicable disease. South Asians, for example, with diabetes. And having those illnesses puts you at increased risk of mortality from COVID-19. Usually the conversation stops there, but then the step as to why people have increased risk of non-communicable diseases, it isn't a clear-cut answer, but the next step of structural forms of racism that lead to people having poorer access to the health system, having kinds of occupations that put you at increased risk, having increased risk of non-communicable diseases, that's where the discussion should go to, but usually it doesn't, and it usually stops at, oh, someone has diabetes. So I think this is broadly some of the reasons why the COVID-19 is more common and the mortality is more common. And hopefully we're going to start addressing some of these issues as numbers increasing this winter.
What I'll add that from the US perspective is this is what we're seeing among marginalized racial groups in the US for Blacks, Latinx populations, Indigenous populations, even Pacific Islanders, was predictable and therefore, could have been prevented. So colleagues and I, before the data began to emerge on COVID-19, created a commentary that we released through the Interdisciplinary Association for Population Health Sciences entitled Racism in the Time of COVID-19, where we outlined these very factors that would lead to increased exposure, increased transmission, and differential susceptibility to morbidity and mortality. And also aligned ourselves with some of the social movements on the ground who were calling for a just and equitable response to the COVID-19 crisis. And so we highlighted some very similar factors that Dylan has eloquently laid out in terms of who were our essential workers, disproportionate Black, Latino populations in these service industries and production industries, who had the privilege, for example, to stay at home, again, disproportionately white individuals. We also knew that there's existing structures, things like racial residential segregation that has a long-standing history in the United States would contribute to the amplification of risk. Because essential workers don't stay at work, they stay in their homes. Those homes are embedded within communities. Those communities then are not serviced by, healthcare, et cetera. And we found even with some data from Drexel in Philadelphia, where testing sites were inequitably distributed in the city of Philadelphia, there were more testing sites in wealthier white communities than in the communities we knew would be most susceptible, right? And so I think, again, all of these factors are in play. They really just highlight the fact that there were interlocking systems, right, and structures that are leading to the amplified risk. And I think, for us and for, so many of us, we saw that it was so many of the systems outside of healthcare, which I think, again, calls on us to really think about the manifestations of racism outside of healthcare and how we can be advocating, we should have been and should still be advocating for policies that are not necessarily healthcare policies. So one of the things early on in the pandemic, we did a congressional briefing with members, mostly of the US House Democrats, where we were saying, we've got to protect workers. workers are literally being sent into their jobs without personal protective equipment, without paid sick leave, without hazard pay. They don't have the option to stay home if sick because of so many other responsibilities. How are we creating the conditions so that they don't literally have to be choosing to, get a paycheck or to be exposed to COVID? We could have done that early on and we didn't. I think it speaks to this fact that, there were so many measures that could have been taken early on, but we didn't center equity. We didn't and have not centered justice kind of in our recommendations for what needs to be done. And so again, I think, and so what we're seeing in the US, upwards of 3 times the risk of death for Blacks, Latinx, and Indigenous populations. Over 43,000 Blacks have died due to COVID-19. That's 20.8% of the deaths, although Blacks make up 13% of the population. And there's another striking inequity that I think we need to be paying attention to. Professors out of Harvard, I have a working paper that's actually currently under review by the New England Journal of Medicine. But what they've also shown us is that it's not that just that Blacks, Indigenous, and Latino folks are dying at higher rates, but also at younger ages. And this gets into this idea of the kind of the life course perspective of racism and how even for Blacks and other minority groups, the experience of racism are compounded, show up earlier, and then can lead to more susceptibility to things like COVID-19. So we're seeing, they showed some data at a recent webinar that I saw where for Blacks between the ages of 35 and 44, the mortality rate compared to whites is 9 times that of whites for Blacks, 8 times for Indigenous, and 8 times for Latinx in the age group of 35 to 44. This is data from the CDC that has been used to kind of demonstrate that it's not just about the higher rates, but the higher rates at younger ages. And I think, again, this is all, a legacy and a manifestation of how racism operates across these systems.
I just need to comment there that your call out for changes to happen, not just in healthcare, but also outside, and the numbers that you quoted there, the 9 times more likely. I mean, if you look at the UK, like Black men are 10 times more likely to be stopped and searched. I think that parallel is relevant in all aspects of life. And Didi, I know you haven't commented on this question. I just wondered if there was anything you wanted to add on COVID-19.
First of all, Dr. Barber, thank you for all of your work in this area. I really appreciate you being at the forefront of it. And also Dr. Delon for your work in UK. I'm just honored to be among such brilliant scholars and activists. I come at COVID-19 from the perspective of pregnancy and maternal child health disparities. And what we're seeing is that we see pregnancy-related disparities have been exacerbated during this pandemic. I literally was texting with someone yesterday who's pregnant with twins. She's 34 weeks, one of my sorority sisters, and she is scared to death that she's going to have to labor alone. And these hospitals are, the policies that they put in place are really stringent. We're not seeing standardization of policies. Some hospitals you can have 1 or 2 people, other hospitals you can only have 1 person. There's no process for supporting women in birth. And we also are seeing an increase in emergency C-sections and medically unnecessary procedures. And so I think COVID has just laid bare what we've already known, that the healthcare system is really broken for Black and brown people, and it doesn't get any better in pregnancy and labor and delivery. So that's kind of the lens that I've been focusing on, is trying to advocate for, 1, a standardized practice across hospitals, 2, for people to be able to have the support people that they need in one of the most delicate / dangerous moments in a birthing person's life, and 3, for just better data on pregnancy-related morbidity, pregnancy-related mortality as it pertains to the COVID-19 pandemic. So we have a ways to go, but we're seeing a really haphazard response to pregnancy and delivery around COVID.
Can I just pick up on a very small point? And both Ndidi and Sherelle kind of mentioned this. this isn't unusual. So COVID-19 is an extreme example and a very obvious example of what's happening, but this happens across all health outcomes and in, inequality groups and amongst minoritized populations. This is not unusual. And maybe COVID-19 we can use to push the agenda for other issues, maternal child health, but everything really that different groups, and as Sherelle mentioned, the illnesses, they're also more common, but they happen at a younger age amongst most groups as well.
Thanks. And I think we could touch on a topic that's come up in the news in the UK the last few days, and I think it was mentioned in the US executive order as well, which is the topic of critical race theory. I'll open the floor perhaps to Sherelle or Delan to kick us off, but I feel like it's something which needs to be talked about.
Absolutely. And what I'll say, even in, kind of so many of us who could have predicted what would happen with COVID-19, one of the reasons is because we are grounded in a kind of critical risk perspective of how racial inequities emerge with regard to different health outcomes, right? And so, and it has been shocking to see the kind of direct action from the highest, office in the land against something like critical race theory. But it's not, again, surprising with this, current administration. Just to give a little bit of background, this critical race theory originated among a group of legal scholars, right? Namely Kimberly Crenshaw and Derek Bell and others. And they really were trying to create a framework that helps to delineate the ways that racism operates beyond this overt racist expression, right? So how it finds its way within the systems and structures, sometimes not being as obvious, right? Because it's not the kind of overt racism that we saw in the past. And so, critical race theory really challenges us as a country to think about the systems, think about the structures, and think about the policies, the politics, and the ideologies that have led to these systems and structures that maintain racial hierarchy in the United States. And we don't want to deal with that. But we have been forced to deal with it, one, because of the COVID-19 pandemic, but also two, because of the vicious murders of Breonna Taylor, George Floyd, Ahmaud Arbery, and so many others. This kind of confluence of these two things, the racial inequities we're seeing with COVID-19 and this very overt and violent racism, we've had to contend with that, contend with the history of how we got here, and really forcing a reckoning that America's very foundation is built on racism and white supremacy. And a lot of folks don't want to deal with that reality, that truth. And so critical race theory just challenges so much of what most Americans know about America, and the truths that it doesn't want to deal with. But again, if we are going to actually kind of dismantle these systems, disrupt these systems and these structures, we have to have this critical perspective on our history, the systems and structures, and how they came to be, because it wasn't by accident, but by design, right? And so, we're in a point where we have to kind of, come together and do this kind of truth telling, because it's the only way that we're really going to be able to move forward and do the kind of reconciliation, the kind of healing that's necessary in this moment. Dylan, you made a great point. Perhaps COVID-19, is something that kind of forces us to reckon with these things. And I think, again, critical race theory is a framework with which we can do that. And the powers that be don't want that to happen.
I think you made a very interesting comment there. Americans don't want to deal with that truth. My optimism is slightly tempered this week in that it's a particularly sanguine moment in the UK where we were talking about critical race theory. An MP, Conservative MP Kemi Badenoch, spoke in the House of Commons about critical race theory. And I took a couple of quotes from her that teaching children white privilege is illegal, or it will be illegal in the UK. Many people don't realize that critical race theory is political. It's getting into institutions that really should be neutral: schools, NHS trusts, and sometimes even the civil service. This is a particularly kind of sanguine moment, I think, for us in the UK, where the discussions, I think, are also a little bit further behind, but the optimism of we can use COVID-19 to move forward is also countered by statements like this from the government. And I know, because I spoke to her people in her unit, the race disparities unit. I talked to them about these issues, and it's scary in many respects. And even the fact that the NHS is neutral. I mean, the NHS wasn't neutral when we had a hostile environment towards migrants. It was very not neutral. It's not neutral when we deny care to undocumented migrant children in the UK. And these are children, half of whom are born in the UK, but are undocumented because of the status of their parents. Just the fact that it's illegal to talk about white privilege. So I was actually thinking today I have a project in school focusing on xenophobia in health. And it's really interesting. They've asked us to expand this and to do more sessions, and we were going to go into wider issues. And now, can I not talk about white privilege? Can we not talk about the history of the UK, the colonial history, the reasons why we are where we are? It's a very kind of worrying moment. And what I think about actually is some of the parallels with climate change and how the narratives can be changed, how the stories can be changed. Yuval Noah Harari had an interesting quote that humans think in stories. We create the sense of the world in stories, but these stories are adapted. There's a very interesting podcast, a series of podcasts called Drilled, that talks about climate change and the oil industry and how they change the narrative. They change the narrative through science partly and through the media, and they change the story so that truth and facts became disputed, that they weren't truth and facts. They, as Kemi Badenoch said, these are opinions now. And we've always known this, going back to Joseph Goebbels. If you repeat a lie often enough, it becomes the truth. And this process is happening here in the UK right now, when we have much higher mortality rates amongst Black people, other minority groups. So I think, as much as it could be a time for optimism, it is a worrying time here in the UK.
Absolutely. And 2 points I'll make, that it's just to kind of follow up on what you said. It's just the idea of the production of knowledge. Critical race theory challenges that, not only and really gets at who gets to produce knowledge, right? Who gets to produce facts, right? And I think that's one of the reasons that, again, voices that have been historically marginalized in the knowledge production, systems need to be centered in this moment, because the reality is we can't ignore the impact of racism in our communities, in our, for ourselves, right? It's something that we don't have the option to ignore. And for it to be so blatantly disregarded in this moment, really is a gut punch, to our lived realities and the lived realities of so many who are suffering. And so, again, I think it's really critical in this moment that we, again, continue to push against this move, and some are really calling it a move towards authoritarianism, where we, really crucify and dismiss the dissenters within our society. And in this moment, we just, aren't possible. So the glimmers of hope are the folks that are continuing to resist, the folks who are continuing to, to continue to amplify this narrative, this counter narrative, even despite kind of the ways in which it's the attempt to silence it in this moment.
I think that would be a good moment for me to thank Elsevier for letting me do this presentation right now. I also wanted to just say a quote that came from, it was a TV series on Chernobyl, when you mentioned lies and truth. It was talking about what is the cost of lies. It's not that we'll mistake them for the truth. The real danger is that if we hear enough lies, then we no longer recognize truth at all. And I think you're talking about the optimism at the moment, but I'm quite skeptical at the moment, to be honest with you. I know I'm should be a very optimistic person because I'm a younger person, but I'm not at the moment, to be completely honest. I think maybe we could quickly touch on we're talking about the intersection between racism, the environment, perhaps also pollution as well, we could touch on. And then I think at the half an hour stop point, we'll move on to some of the Q&A questions from the people before.
So I can speak a little bit about this, but I wanted, Ndidi, did you want to comment any more before I did? So I think the discussions around racism, around the environment, around climate change, these are the major causes of ill health. So Michael Marmot, who's worked a lot on health inequalities, talked about 3 structural drivers of health inequalities, and that's macroeconomics, the environment, and structural racism and colonialism. And the way these interact are kind of fundamental to the health of populations. And there are issues, very specific issues, like how air pollution affects COVID-19 mortality, morbidity, and the fact that it tends to be poorer people, particularly poorer ethnic minority people in London, for example, are at higher risk of outdoor air pollution and have worse morbidity from COVID-19. So these interactions are very tangible at the moment. There are then these sort of environmental disasters and hazards that have happened. If we look back to India, for example, the Union Carbide in 1984 in Bhopal, the disaster that led to this chemical leaking out into the population, a poor population where thousands of people were killed, many thousands more. We don't really know how many thousands more affected longer term in terms of morbidity, early mortality. But a lot of this is actually more insidious, that these environmental controls being pulled back on allows chemicals, for example, to leak out into the environment and affects the most disadvantaged people, the people who are already disadvantaged for many other reasons, already minoritized for many other reasons. And just one example. So we're going to do a podcast looking at indigenous populations in Brazil and deforestation and some of the laws in Brazil, and how repealing of some of these laws by Jair Bolsonaro's government has led to this encroachment, I guess, easing of deforestation, which affects indigenous populations much more than other groups. And, we are to blame here as well. The global trade, what we buy, the sort of carbon emissions. It's not just a Brazilian thing, but this impacts on particular groups, in that case, particularly indigenous populations. So all of these things are combined, and we can't look at one in isolation.
Yeah, I'll say, we see similar patterns here in the US, and particularly in the city of Philadelphia. There's a community in South Philadelphia that has been impacted by a refinery for, decades upon decades upon decades. Again, a formerly redlined community, again, segregated, racial, Black and poor community, but decisions to, place individuals, low-income individuals in these kinds of communities, happens across the country. And we see the health effects with regards to things like asthma, higher rates of cancer, et cetera, being, found in places where these polluting industries are placed. So this issue of environmental racism, again, is another, serious factor that needs to be, addressed here in the US and around the world.
Might just touch on that. There was a TV series released by, David Attenborough was at the forefront of it. It was called A Life on Our Planet. I found it very interesting that they did focus on the amount of land which is left as being a key issue. But one of the 3 data points, it was the time, and then the second one was the size of the population globally. My view is that the population is focused on and the blame is pointed at where it's not really due. I just wondered if anyone had any thoughts on that. And if not, no worries. It's a passing thought, and we can move on to the, I think some of the Q&A questions from before the session. Ndidi, I think the first question would be most relevant for yourself. It's how can we help combat the high maternity mortality rate among Black women in the US?
That's a very loaded question. I think one, as I've mentioned, there are a couple things we need to do. One, we need to have more physician congruence with their patients. So we need more Black and Brown people in the physician workforce. And so that goes back to the tracking in elementary school and discouraging and dissuading Black and Brown students from taking up careers in science and medicine. We know that's a very clear thing that happens here. We have these young minds that are brilliant and want to go into medical school, but they're persuaded to go into something else or allied health or things like that. Two, we need to reimburse doulas, and that's another kind of legislative fight that I'm a part of here. We need to reimburse doulas at a livable wage. Doulas, which are considered to be support people for the birthing person, are oftentimes not even able to feed themselves. I mean, I have an 18-month-old son. When I had him last year, I had a doula and I paid her out of pocket because I had the resources to do so. Doulas are not reimbursed as part of the healthcare team. So we need to make sure that doulas are able to support themselves and also to support women. And then three, we need to really dismantle the racism in these medical systems and providers and healthcare professionals, everyone from the moment a birthing person walks in the door of the hospital, how are they treated, how are they received, what assumptions are made of them, what assumptions are made of their pain, of their symptoms, and really prioritizing the needs of them in their labor and delivery. And then another thing I want to just lift up is this country has a really ugly history with Black midwives, and Black midwives came out of, Julie, I'll explain in a second. Black midwives came out of really a necessity for women to have support because we weren't getting the treatment we needed at white hospitals. This is segregationist South, 1950s, 60s, and you saw this real upsurgence, even prior to then, of Black women taking care of ourselves and taking care of each other. So we'd have a community model. We'd have Black midwives who would help with and assist with the labor and delivery, help to do everything that a doctor would do in our own communities by our own women. And then we saw the medicalization of midwives, right? And so that now, because people are starting to see that there's something to it, and so white women came, changed the whole model, and now you have to be certified, you have to have a certain amount of education, you have to have all these credentials to do midwifery practice. So you took something that came organically out of a need, really an urgency in the Black community to address pregnancy and to be able to support Black women. You medicalized it, made people have to go to school and get certification for it. It became a very profitable, a high profit margin for white women. And so then we saw the number of Black midwives really decline. So now we're seeing a resurgence of Black midwives in and out of hospitals. And also, just to really talk about the need for additional birthing centers. We know that hospital systems are failing Black and Brown women. So if we're going to address maternal mortality, in addition to the things I said, increase the number of Black and Brown physicians, have more physician-patient congruence, have an additional focus on doulas, have an additional focus on midwives, Black and Brown women need to be able to labor in birthing facilities. We need to focus more on home births to give people the support that they need. And we need to make sure that they have a supportive care team. And the last thing I'll say is, on one of my studies that I just got funded for, I'm the principal investigator of an R01, which here in the United States is federal funding from NIH, and it's a 5-year grant looking at the implementation of maternal safety bundles. Maternal safety bundles are interventions that we know reduce morbidity and mortality. So the 3 that we're focusing on for this grant, we're working with hospitals across the state of Massachusetts that have at least 50% of births to Black and Brown women to implement maternal hemorrhage, maternal hypertension, and racial disparities, anti-racism bundles, because we know these things impact birth outcomes, maternal outcomes. So we got the community side with increasing doulas and midwives and creating a pipeline of Black and Brown scholars who are going into medical school and medical profession. Then you also have the clinical intervention. What happens when a woman starts hemorrhaging in labor or post Thank you. What happens when a woman starts laboring in labor or in a postpartum period, right? What does that mean for her care? A lot of women are dying because we don't know what to do. The hospitals are not prepared to respond. A woman starts hemorrhaging, have the blood ready, have the transfusionist ready. Like these systems that we can put in place in a clinical encounter are, to me, very seamless and obvious, but they're way overdue. We have not coordinated it well. Also addressing some of the chronic illnesses that we see that Black women are more likely to have: hypertension, gestational diabetes, and more likely to have preeclampsia. How do we address those? How do we ameliorate them? And how do we intervene earlier? So those are some of the things that come to mind. Thank you.
Thanks, Ndidi. I think the next question we could go on to is from Melinda. So it's, what impact, if any, would universal healthcare have on racially disparate outcomes here in the US?
So I'll take a stab at that, and indeed, please feel free. I think that one of the things that again, I mentioned this earlier, that the COVID-19 pandemic is showing us that so much happens before the healthcare system. We get to the healthcare system. So while changes in the healthcare system are absolutely necessary and critical, we have to be looking at the broader, what we call the social and structural determinants of health that occur way before individuals and get into the healthcare system. So yes, does everyone need to have access? Absolutely. Does it need to be universal and free? Yes, absolutely. Because society actually makes poor and marginalized racial groups sicker, so they're going to be, need the healthcare system more. But again, I think that is only one part of the solution. We have to begin to think about the systems and the structures that are actually making it so that marginalized racial groups and other groups are disproportionately impacted by a wide range of health outcomes. And so one of my focus areas in my research is racial residential segregation, which has been seen as a really fundamental driver of health inequities because of the ways in which it structures opportunity, but it also leads to overexposure to harmful exposures such as pollution, lack of access to healthy foods, and all those things. And so I think another approach is to think about how we create thriving communities, how we create communities that have the opportunities where people can be healthy. That is another approach, another way that we can address the wide range of health, racial inequities, I think, that exist in the United States. And they're models for, how communities have come together to advocate for the kind of necessary policy changes, both at the local, the state, and the federal level that support, again, healthy communities that allow people to thrive. So yeah, so that's what I'll say to that point.
Thanks, Cheryl. Maybe go to a question that came from before the discussion. I don't know the context of this question. I'd love to hear the panel's thoughts about the racial origins of fat phobia and its impact on healthcare. I'm not sure about that question. I do encourage you to carry on posting your questions in the chat though, but I'll move on to another question. This one, I think we discussed actually, all of us, a few days ago. It was, what advice would you give to scholars and the audience today wanting to be more impactful activists? That is an optimistic question. I like that one.
I can start because I think we all need a little bit of optimism. I get this question often, and even in my lab, I run a lab for for students who are interested in maternal health disparities, called the Mother Lab, Maternal Outcomes for Translational Health Equity Research. And we're doing our official Twitter launch on Thursday at 5:30. So if anybody wants to follow me, we're going to flood Twitter. I have 28 beautiful Black and brown and other students. And what I tell my lab members, who are just so, disproportionately impacted by it, but also trying to ameliorate this work. And when you hear the statistics, Black women are 243% more likely to die from pregnancy-related complications, and it just kind of beats down your spirit. What I tell my students is that, one, we are the ones we've been waiting for. Okay. Nobody's coming to save us. The federal government is not coming to save us. Our elected officials are not coming to save us. Some of them maybe, but the majority of them, no. They're self-serving. When you see people that have been in Congress for 30 or 40 years, how can you be effective? How can you're so far removed from what's happening on the ground. So I tell them we are the ones we've been waiting for. And two, they're like, how do we address these disparities? The burden of racism feels so heavy. And I say all of us have something that we can do, whether it's educating your in-laws around the table, whether it's protesting, whether it's advocacy, whether it's using your voice, using your power. As students, you have power. You pay tuition, your constituents, right? And the universities are beholden to you. I tell students that all the time, even my undergrads. Understand your power and your positioning in this relationship. It's not, oh, thank you for admitting me. It's like, no, I'm paying tuition. What am I getting in return? So training them to be scholar activists. And two, the glass is always half full, right? You have to, for you to have longevity in this work, you have to know that, any incremental change is still change. Any incremental progress is still progress. And a lot of the situations in my career now, I'm sitting on boards, I'm sitting in national leadership positions, and I am pushing these organizations to do more. It's uncomfortable, right? I'm oftentimes one of few of only Black people in the room, and I'm always telling them, use your voice unapologetically. And I tell people now, I just turned out a board request about 2 weeks ago, a really reputable organization. I said, listen, one, you're not doing the work. Two, there's very few other people of color. Three, go back and do something and then come and ask me in a few years. Like, you have to understand the one, you're in a position of power, and two, we all have a role to play. So yes, you might not be leading an R1, you might not be sitting on a national platform. Even as a student, even as a young person, get online and do something. Look what's happening in my home country of Nigeria right now with the End SARS movement. That's being led by the youth. I am so incredibly proud of what I'm seeing. And it's not just Igbo youth, which is my tribe. You also have Yoruba, you have, I would like, people are coming together to dismantle this racist, patriarchal, discriminatory, disgusting system that we have called SARS. If anybody's interested in what I'm talking about, just hashtag end SARS, SARS. That's being led by young people. And they're fighting the government. They're holding the government. And then the people, our elected officials, are escaping to UK. They're coming to UK, and we're finding them in the streets of UK and holding them accountable there too. So that's a current example that I'm just so proud of. And I really implore young activists to not be overwhelmed by the enormity of the situation, but to understand within your sphere of influence, you can create change through your life. When you look back over your life, what will you say that you were able to do?
Sure. Well, I was just going to emphasize that last point about the student and student power. We had a conversation with someone in my group recently, so we were talking about UCL, so our own university, and so UCL is the home of the eugenics movement, going back to Francis Galton and others, Carl Pearson. And there's been a movement to change the names of lecture theatres and different things within the university. And I was saying that the student movement is much more powerful than anything I can do. I could speak to a few people, but there would it would be much more effective going through student groups. And one is the sort of the numbers. So there are huge numbers of students, but also the kind of the financial power that students have. Universities are also beholden to students, so the students do have a voice and can certainly make change. And just a couple of other things is that it's difficult to do. So I think when people, sort of activists, go into these kind of fields, you need to be in it for the long run. That making change is not an easy task usually, and it takes lots of effort. And it's not only on social media. It involves speaking to people, going out. I mean, not currently you should stay indoors, but normally you should go out and talk to people. The other thing is going back to the point about stories and narratives, and engaging with other people as well. Engaging with people who may lose something or may perceive that they are going to lose something from this process. We have to engage with everyone, and my own approach is to work with children and younger people and have these discussions at a younger age, and take very abstract concepts and talk about it in an abstract way and then make it real. So I think that process, and I see this, so I'm a researcher, I mostly have quantitative data, and I know that it's not that useful if I quote numbers to people or risk ratios or something. It sort of doesn't work. But if you make it real, you create the narratives, that's much more meaningful and can be much more powerful. Sorry, Cheryl, over to you.
No, these are all great. And, and I appreciate the different models of activism and scholar activism, really. One of the things that I've learned actually over the last 6 to 8 months with the COVID-19 crisis is the power of aligning with existing social movement. So I've had the privilege of working as the health justice lead of the Health Justice Advisory Committee on COVID-19 to the Poor People's Campaign, which is a national movement in the United States, really looking at the intersecting injustices of systemic racism, systemic poverty, ecological devastation, and militarism. Convened a group of scholars from across the country to really advise the movement as they were positioning themselves to challenge things that were happening at the federal and the state level. What is inspiring about this movement has different organizing communities across 45 states, but it is led and amplified by those most directly impacted by these issues. And I think another part of activism, as we've tried to find our way and try to find as scientists try to find our way in this, is aligning ourselves with those who don't have the degrees, because they have so much critical knowledge about the issues and actually have some very invaluable knowledge about the solutions, right? And so the extent to which we can couple our expertise, right, with those who are most directly impacted. And, I learned so much more from them, hearing their stories, hearing the ways in which they have to navigate, but also, again, being inspired by the fact that, even in the midst of a global pandemic that is disproportionately impacting so many communities, they have found ways to organize and galvanize and really push the envelope on what is possible, right? And so, one of the things that I would say is that find ways to align with what's already existing, because as an individual, we're relatively weak, but when we can find power in the collective, find power in the social movements already happening and support those movements, I think we can, push the needle in ways that, are beyond our imagination, beyond the walls of the ivory tower, and beyond what's possible, without this kind of movement. So that's been something that I've learned, just even over the last few years and hopefully, months, and hopefully we'll continue to do that moving forward.
Thank you, all of you. That was very insightful for me as well. Cheryl, your closing comments there about being stronger together, Embrace is pretty much built on that principle, and Axel came up with that, so I just wanted to mention that now. I know we're coming close to the end of the time, so I'm being very selective with the questions I pick now. I think there are 2 topics I think we should cover. One of them is, so we've mentioned EndSARS as a hashtag, as one example, and there are many more that we can follow. And that was a question from Melinda. I can follow up separately on that one. I think we should maybe touch on the impact of technology, in the sense that it can be a course for good, but it can also perpetuate the racial inequities that we see. Just wondered if anyone wanted to take a stab at giving some context to that.
I'll just highlight the work of Ruha Benjamin, the new Jim Code, where she talks about the ways in which, algorithms that we're creating, et cetera, especially when they're based on data that arise from racist systems and structures, can really perpetuate inequities in so many outcomes. And so I think technology can be wielded, possibly for good, but we also have to just examine, how they're being used. For example, even with COVID-19 and, using different forms of technology for surveillance for certain communities that have been surveilled because of over policing, because of, in the United States, Latinx and immigrant populations who have been, intimidated by ICE and other things. That kind of technology that tracks like who you've been in contact and where you've been, is invasive to communities that have been where this kind of information has been used against them and to harm them. So again, a use of technology that is attempting to mitigate the spread of COVID-19 in this time, but can be misused and can be mishandled if not done in the proper way. So I think again, technology can be used as a tool, but we've got to recognize that technology arises within these systems and structures, has these biases that might be embedded in them consciously or unconsciously that we definitely need to be taking into consideration.
Thanks, Shreya. And the last point, which we have briefly touched on throughout this discussion, is, I suppose, the impact of racial inequalities on mental health. So something that I hold very close to my heart. I was diagnosed with clinical depression early on into lockdown. So I hope someone can maybe pick up this discussion, and we'll end 5 minutes before the end. I'll give a closing statement.
I'll just say, one, thanks for being that vulnerable to share that, with us. But I do think that a part of this moment where we're seeing a lot of protests, a lot of action in the street, a lot of fighting against, these structures, these power structures, we do, need to acknowledge, how traumatizing, it all is. Traumatizing, as we're fighting, but also traumatizing because we have to bear witness to things over and over again. One of the most heartbreaking things that has, happened in September was when no one was charged with Breonna Taylor's murder. After, and the ways in which that just signals a total disregard for the life of Black folks. But to have to, again, experience that over and over again, and there's research documenting that there's vicarious trauma that happens to those who aren't even a part of the encounters with police, right? So, we know it's documented. And so again, I think in this moment, it's important to recognize that racism, the experiences of racial trauma are real, acknowledge those. And then in this moment is really a moment where we should embrace, radical self-care and care that we get from, community, right? Because one, the COVID-19 pandemic is not over. The level of trauma and suffering that we are experiencing in our communities, unfortunately, is also not over. And so what are the ways that we really take care of ourselves and our communities in this moment? Because this isn't normal. Racism isn't normal. The kind of trauma that we have to bear witness to isn't normal. I think it's critical to recognize it, but also find ways of caring for ourselves and our families and our communities.
Yeah, thank you for that, Sherelle. One thing I will say, and this comes up in my lab often, I think the impact of isolation is real. The impact of this racialized trauma that we see, and how I'm even thinking back to Michael Brown's death, and they, left him in the street for hours. And what does that mean for the community there in Ferguson when you see just the disregard and disrespect of a Black life? And so I just would encourage all of us that are freedom fighters to take care of ourselves in this moment, to disconnect when we need to disconnect, to recharge when we need to recharge, to get the help and resources that we need to sustain ourselves. And I just really would implore all of us to prioritize ourselves, because if we're going to do this work, we have to show up fully. And to show up fully, we cannot continue to be re-traumatized every time that they show these. It's just the callousness seriousness of it is just very disturbing to me. Anytime we see something happen and they keep playing the clips and playing the clips and playing the clips, it just really is a disregard for Black people and people of color, and what that means. What does that do to our psyche? So, like Sherelle said, we need to continue to take care of each other, love up on each other, be kind to each other, be patient to each other, and disconnect. If you need to take a mental health day, put your out of office up and take the day. And you don't owe anybody for that, right? Like you don't, that should be, there should be no second guessing or no, qualms that come from that. Do what you have to do to prioritize yourself and your health, because we know these systems were here before us, and these systems, if we're not here, they will continue to roll right over us and keep perpetuating the same racism that we're working to dismantle. So that's a reminder for all of us to just take good care of ourselves and be kind to each other in this moment.
Thanks, Ndidi. I agree. And I think I'll stop here because I really want to continue this conversation. I hope we do continue this conversation offline. For now, I'd just like to thank everyone on the panel, everyone in the audience. You've all been amazing. I've seen so many comments coming through. I'll just give a thank you to the Embrace committee as well. So we have Anita, Anna, Eileen is also on here, but not on the screen. Antonia, Ash, Catherine, Edith, Francis, Havon, Laura, Mandeep, Maxine, Nicole, Michelle, Morgan, and Saffron, and of course my co-founder Axel, and also our executive sponsors. We have Mayu Lee, Kevin Holloway, and Tiffany Lewis. And I'd also like to give I suppose a brief closing statement. I think that the goal of this 3-part series is to enable you all to have more impact as an anti-racist. And as we've touched on multiple times through the session, this involves accepting hard truths. On Britain's response to COVID-19, my colleague and the editor-in-chief of The Lancet, Dr. Richard Horton, said, "It's the biggest science policy failure in a generation." As Dr. Deland Devankumar and Dr. Sherelle Barber put it respectively, COVID-19 has been the great unequalizer. Its devastating impacts and the senseless murders of Black people have brought into sharp focus the deadly consequences of racism in the US, Nigeria, the UK, and beyond. And since June, grassroots activists and the Black Lives Matter movement have mobilized millions of people around the world. These are the largest anti-racism protests in human history. Many listening right now peacefully protested. Many put their lives at risk from police brutality, as well as the lives of their loved ones at risk from the pandemic. Like movements like this one that organize from the bottom up demand a radical restructuring of our society and a reimagined world where all Black lives truly matter. Black queer lives, Black trans lives, and Black women's lives. Dr. Ndidi concluded recently that medical educators must address racism in medical education before seeking to direct students to address it in medical practice. Students and medical professionals use technology from providers like Elsevier to make life or death decisions. I believe we have a responsibility to understand whether or not the technology solutions we provide are reducing inequalities or making inequalities worse, as the United Nations reports to typically be the case. While I've worked at Elsevier for 2 years, I've lived in my skin for 27 years. This entailed exclusion by other school children, police profiling, violent experiences of racism, and as a UK, not a US citizen, empty threats via Facebook. Corporations such as Facebook have economic and business models that mean they actively profit from misinformation, discrimination, and intolerance. In contrast, as representatives of your institutions and organizations, I'm inspired by your commitment to listen in today, wanting to champion anti-racist change in science and healthcare and beyond. I'm encouraged by the group CIO of Relics, Dan Ollie, providing tools and a plan for employees to suggest and integrate impactful anti-racist changes into our technology. But as our CEO stated, we must reevaluate. Beyond science and healthcare, I think all profit-driven organizations, particularly those without diverse teams with the same unconscious biases, must question how we can sustainably operate responsibly, spot mistakes, and anticipate future risks. I believe companies must commission independent advisory panels of experts, like those you have joined us today. Independent experts assigned on merit to provide anti-racist consultations with clear measures of success. We then owe it to our brands, ourselves, and the societies which we all live in and serve to follow through and implement these anti-racist recommendations by the experts. I hope you'll all join me in congratulating our panel today via the chat function for today, their years of research, scholar activism, and their vision for the future of anti-racist corporate responsibility. You'll receive an email of this recording in 7 days. Our Microsoft Teams link for Elsevier employees and our email address for everyone as well. Please let me know by email if you truly want to start implementing an independent scientific advisory panel for your organization. I'll invite you all to continue the discussion next week. That's 2 o'clock UK time, 9 o'clock US East Coast. The link to register is being posted in the chat now. We've touched on this already, but the main focus of this discussion will be the third goal of the 3-part series, which is to support grassroots activism with our skills, influence, and resources for institutional change. I will stop sharing. I hope to see everyone next time. And a final thank you to Sherelle, Delan, and Ndidi for an amazing panel today.
Thank you very much.
Thank you. Thank you, everyone.
Thanks, everyone in the audience. Have a great weekend and happy Friday.
Thanks. Same to you.
Bye-bye.
Bye, everyone.